This webinar is a recording of a presentation by Pam Mosedale on quality improvement, too important to leave to just the vets, which was brought to SPVS-VMG Congress on the 13th of May 2021 in partnership with RCVS Knowledge and kindly sponsored by Citation. Pam Mosedale is QI Clinical Lead at RCVS Knowledge and Chair of the RCVS Knowledge Quality Improvement Advisory Board. Pam was also previously Lead Assessor of the RCVS Practice Standards Scheme.
Thank you very much. I'm going to talk about quality improvement, why I think it's too important to leave to just the vets. In other words, why it's a whole team effort. So I think Gillian's pretty much told you who I am. And RCVS Knowledge, who are they? Well, they're a separate organisation to the RCVS. The mission of Knowledge is to advance the quality of veterinary care for the benefit of animals, the public and society. And we do this by championing the use of evidence-based medicine, and by, we hope, inspiring a culture of continuous quality improvement in practices. We have some great resources available to the profession and the public, and they're all free, and we'll talk about some of those as we go through the presentation. So quality improvement, QI, why is it important then? Why should you bother with it? Well, for those of you who are vets or RVNs, it's in the Code of Professional Conduct that you must make clinical governance part of your professional activities, and quality improvement is part of clinical governance, and we'll talk about that in just a moment. For those of you who are practice managers or head nurses, you probably think about clinical governance because of the Practice Standards Scheme, because the clinical governance is one of the modules of the RCVS Practice Standards Scheme. But I think it's much more important than just the Code of Conduct or just practice standards. It's about improving outcomes in the practice for your patients. It's about improving service for your clients, and it's about improving the way you work for your team so that we can all enjoy working and have a positive experience at work. So getting back to clinical governance then, this is an NHS definition from when clinical governance came in to the NHS back in the 90s after various kind of scandals around some procedures that were being done which were not perhaps the most up to date. But the important thing about this definition is it's a framework. It's a framework through which organisations are accountable for continually improving quality of services and safeguarding high standards of care. Now, I don't think any of us would disagree that that's what we want to do when we come to work in a veterinary practice. We want to provide good quality care, excellent quality care, and good service. And so clinical governance is a framework. Now, I always say, I've been in practice more than 40 years, and we've always done it. And we've always done it. We've always discussed cases. We've always thought about what we do and how we could improve. But clinical governance is about having a framework, actually deciding what you're going to do, establishing it, having a policy and making sure it's done consistently. And practice standards at general practice level, which is probably what most practices are at, wants you to have systems in place for talking about clinical cases, analysing and improving professional practice as a result. And a bit of a news hot off the press for you, the new edited version of practice standards is due to come out very, very soon. And clinical audit, which was in the veterinary hospital level, has now moved to general practice level. So we will expect practices to be doing clinical audit, either process outcome or significant event audit, and we'll talk about all those today, or development of guidelines and protocols. And that's coming into general practice soon. So it's going to affect more practices. So you say, what's the difference then between clinical governance and quality improvement? Well, clinical governance is the framework, as we've said, and it sets out what we have to do. And you know that it covers all sorts of things. It doesn't just cover clinical things, it covers health and safety, IT, CPD, HR, all those kind of things are all part of clinical governance, as all the practice managers on here will know. Quality improvement is about a systematic approach to the enhancement of performance. It involves use of QI tools we'll talk about to identify gaps, in other words, see where we're not doing as well as we think we might be, analyse data, and then make some changes and test the changes, leading to continuous improvement. So basically, putting it simply, which is what I prefer to do, clinical governance tells us what we should be doing, and quality improvement tells us how we can do it and shows us how we can do it. So here's another definition of quality improvement from Battleton and Davidoff. Quality improvement is the combined and unceasing efforts of everyone to make the changes that will lead to better patient outcomes, better care, and better learning for the team, better professional learning. Now, I think the important thing there is everyone in the practice. I was reading something a while ago about someone working at one of the American space station in Florida, who was the cleaner, and somebody asked him, "What do you do around here?" And he said, I send men into space. Everybody who works in veterinary practices fixes pets, basically, if they're small animal practices, or provides veterinary services to farms or horses. Everybody, whatever your role in the practice, you're all an integral part of how the practice works. The practice can't work without you. It's not just about vets, and it's not just about clinical stuff. It's about the whole practice team. So yes, quality is everyone's responsibility. Everyone in the practice has to think, what's quality? What do we want for the practice? And I think it's always quite a good brainstorming session you could have in your practice. Is the care we're providing quality care? What do we think we should be doing? How can we better support our patients, support our clients, but support our team members as well? So to help with this, RCVS Knowledge has some QI tools. We've got a QI toolkit, and there's tons of stuff on there. There's a whole section on guidelines and protocols. There's a whole section on clinical audit, on significant event audit, on checklists, on benchmarking. All those sections have a course to go through. They have real life proper case examples. They have templates to use for audits and for significant event audits. It's all free. We'd love you to use it. That's what it's there for. Just use it. If you do use it, we'd quite like you to acknowledge where it came from, but there's no charge for any of Knowledge's resources. So getting down to the practical then, what can your practice do to improve quality? It's quality improvement, it's what it says on the tin, it's about improving quality. Well, communication, practice meetings, feeding back information from when people have been on CPD courses, running journal clubs, looking at the evidence base, doing some audit, some clinical audit, and we'll talk about that in a little bit more detail, using some protocols and guidelines, using checklists and systems of work, and then that big elephant in the room we'll talk about at the end, practice culture. Now, all these things individually, I could probably talk about for an hour for each. So it's just going to be a bit of a scamper through them, and I apologise for that, but hopefully it'll give you a taste and then you can follow it up later. So practice meetings, you know, love them or hate them, we all have them, and I think we're all used to having them like this now on Zoom and Teams and WhatsApp, whatever. But it's really important to organise those regular clinical discussion meetings. But there's lots of things which affect clinical, which affect the whole team. It's what practice standards don't want you to do for practice meetings is just have the ones where you talk about you know, where to park and how to charge properly. It's about how the practice runs. It's about anything that impacts on the care of the patients or the running of the practice. And the important thing with these is to record some minutes and actions and to have a good system for people to actually input items to the agenda. So maybe having that client on the PMS system misses quality improvement, so that it can be accessed at all branches, so people can pop on there and put something on for the next meeting. I used to find that a very, very useful thing when I was locuming, to be able to do that. When I think of something, just pop it on there, then they have the next practice meeting, it's there, and they can ask me why I put that on there and what we're going to discuss as a result of it. So practice meetings are really important. Communication, I mean, we all know, don't we, that communication is the absolute key to veterinary practice. Communication with clients in a way they can understand, communication within the team, listening to the team, hearing what they say and thinking about it and doing something about it, and then clinical communication within the team. So that closed loop communication, where we don't have the communication errors where somebody says, inject, please give that black cat Metacam, when actually the person goes, well, which black cat is it? And then they can reply, I am going to give this black cat, Susie, 0.2 mils of Metacam cat injection, just so that it's really clear, the communication. And I think I have done some complaints investigation at the college back in the past, and communication, or lack of, is at the root, I would say, of 99% of the concerns that go to the college. So communication is extremely important. So having practice meetings, maybe running journal clubs, looking at evidence base and help with drawing up your guidelines and protocols, but communication within the team and with the clients is so important, and that's for the whole team. It's really important as well, I think, that front of house staff get included in meetings because they need to know. I mean, it may be that you're getting a new bit of kit and it all could be quite technical, but it's important that you front of house team know all about it, because clients are going to ask and they're going to be able to give an explanation to clients. How often do clients go out to reception after seeing the vet and go, well, they said this, but I'm not really sure what it means. You know, maybe it's just me, but that's what I've found. So they're really an important part of the team with that. So let's get on to clinical audit then. Well, please don't be put off by the fact it's called clinical audit. It is a process for monitoring and assessing clinical care with the view to identify and action areas for improvement. So yes, it does mention clinical care, but there's so many things that impact on clinical care, like, for instance, how you get informed consent, how you communicate with clients about that, how around infection control. All these things impact on clinical care, but aren't necessarily what you'd think of for clinical audit. But the most important thing is, if you don't measure things, how do you know what needs to improve? You can think you're doing absolutely great, and hopefully you probably are most of the time, but you don't know how well you're doing unless you actually measure it. So it's much more powerful to come to your team and talk about something that's happening if you've actually got some evidence of what's happening. Otherwise, as W. Edwards Deming said, you're just another person with an opinion. If you've got data and you've got evidence, then it's easier to start to look at how you can improve something if it needs improving, or give yourselves a pat on the back if it's doing okay. So it's a really important thing for the team to be able to find out how they're performing. So we're going to look at the clinical audit cycle. Please don't be put off by this. This is my favourite illustration, if you like, of the clinical audit cycle. So the first thing you have to do is choose a topic for an audit. Okay, so you need to choose something that's going to happen often enough to have an impact. It's no point choosing something that only happens once a year or once every 6 months. It's going to take forever to collect the data, and your team you'll have lost your team along the way a long time before if you do that. So choose something that's relevant to your team, something that's measurable. No point, again, having something you can't measure, something that happens often enough to be able to audit. So for this example, we'll choose something which around repeat prescribing of POMV medicines, say. So say, for instance, the practice standards have been in and they've said, it's on your report, that you're not getting the POMV medicines authorised by vets. You haven't got an audit trail to show they've been authorised by vets. So you think, okay, how much of a problem is this? Let's do an audit. So your topic, so the next thing you have to do is select a criteria. So criteria are exactly what you're going to measure. So for this, it's going to be, you're going to look at all the POMV medicines that were repeat prescribed to clients that were already on, whose animals were already on the medicines over the last 3-month period. We're going to look at whether they've been authorised by a vet and whether there is an audit trail to show that. So in other words, whether the records show the initials of a vet next to the repeat prescribing of POMV, either in advance by the vet saying this animal can have Metacam for the next 3 months, providing nothing changes on the vet's initials, or on the day by the practice having a system where the receptionist asks the vet and they okay it on the day. So that's the criteria. Repeat prescribing of POMV medicines must be authorised by a vet. And then if you look at clinical audit literature, it says set a standard. Now, in human medicine, they do have standards. They have NICE, their National Institute of Clinical Excellence, which comes up with all sorts of standards and guidelines. And that's great, but we don't really have that in the veterinary world. So we have to set our own targets. And I think target is a much better word than standards here. So we might set a target So this is a legal requirement. So for this, we might set a target of 100%. It's a legal requirement. If we were decided that our topic was going to be how someone was complying with a clinical guideline, how the practice were complying with the clinical guidelines, say for monitoring blood pressure in cats with chronic kidney disease, then we'd set a what we think would be a realistic target of how many cats were to have their blood pressure monitored, which might be 50%, or we'd do the first audit without setting a target, and we'd use the results of the first audit as a target to exceeding the results of the first audit as a target for the second audit. But anyway, they set a target of 100% because this is a legal requirement. So then the data was collected by the practice manager, going retrospectively through the PMS system, looking at the list of repeat prescribing for each day and checking whether each of them had a vet's initials either on the day or in an advanced prescription by having the vet's initials on a note that says can have this medication dispensed for this length of time. So that data was collected over a 3-month period. And then the next part is analysing the data. Now, I've always thought with audit in the past that the really important bit is how to collect the data. But in recent times, I've thought the really, really important bit is analysing the data and discussing it with the team. This is a really important bit. So this practice brought the results back to the team and said, okay, we've had a look and that they were right from practice standards. We aren't doing it as often as we should. In 60% of the cases, there is an audit trail that the vet has authorised it. The vet's initials there on the day, in the book, or or they put through the computer on the vet's initials, or there was an advance prescribing from the vet and the vet's initials. But that means that in so it was actually about 62%. So that means that in 38% there was no record of this. So then the really important bit next is to actually discuss it with the team. And when I say discuss it with the team, discuss it with the people who actually do it, the people on the ground. Let's not make any assumptions that things are being done in a certain way. It's about how work's really done, not how somebody in management or clinical director or at HQ, if it's a big group, thinks things are done, but how it's actually done by the people on the ground. So in this case, when they had the discussion, had the practice meeting, here's the results. The vets were saying, well, actually, we do usually do it, but quite often the PMS is on somebody else's initials and you can't tell whose initials it's on. Also, they said that, they're busy and rushing. The receptionist said that sometimes, although they ask the vets they tell them verbally, but it's not recorded anywhere. And then most importantly, when asked about the prescribing and dispensing protocol, half the people didn't know it existed. The ones who did know it existed said it hadn't been revised for 5 years and it was very confusing. And there hadn't been any team training. And meanwhile, there'd been new receptionists, there'd been new vets and no team training. So after analysing the data, the next thing to do is to think about the changes you're going to implement. So in this case, it was, of course, around writing a new repeat prescribing and dispensing policy involving the team. It was around implementing that and team training. It was around some tweaks to the PMS, so it was easier to see whose initials it was on. And then they repeated the audit, which is the really important bit. There's no point doing an audit unless you do a re-audit, and repeated the whole thing, collect data, analyse data over a different next 3-month period. And the results were 80%. Which is amazing, so much better. It's still not 100%, but life's not perfect. But that's so much better. The vast majority, over 80%, were having the medicines authorised. So it was a matter of going to the team and discussing what was happening with the team and making changes. In the same way as maybe talking about the use of a multi-parameter monitor on animals that are sedated, you might find that the barrier is not that people don't know how to use it, but where it's physically kept. Or with monitoring blood pressure, maybe the barrier is not having a quiet room or enough people, enough team members available. So you need to find out what the barriers are. That's the important bit. Collecting data is really important, but then the discussions and finding out what the barriers are is also really, really important. And then review and reflect and see what you need to do. Do you need to, you can pat yourself on the back and say, this is great, but I think we should review this again in another 6 months or another year, or you can do another audit cycle. So there's so much that can be audited, apart from the clinical things like surgery and anaesthesia and all the things that there's so much in the dispensary that can be audited. There's infection control audits, hand washing audits, and if you have nursing assistants or people working in the wards, then hand washing audits are great things for them to run. Client waiting time audits are great things for reception teams to run. Auditing anaesthetic consent forms are admission forms are great. If you've had an issue with maybe people not giving estimates, you audit the forms, find maybe that with your criteria being that they're signed, they've got the procedure and they've got an estimate, you might find that 100% have got the procedure, 95% are signed, but only 50% have an estimate. So again, look for the barriers. Maybe a new PMS system, nobody knows how to do it. So there are different types of audit. Structure audits, if you want to find out if you've got the right facilities. So if you work in farm or equine practice, a structure audit of a vet's car boot is a great place to start. You find out who's got all the hoof testers or whatever other bits of kit and different medicines. So a structure audit of a vet's car boot is a great way to start. Process audits, looking at how we follow protocols or guidelines. Outcome audits, looking at the results of what we get, and lots of people, when they think of clinical audit, just think of outcome audits of surgical procedures, and that's a very good thing to do, but it isn't the only part of clinical audit. When something's gone wrong or something you didn't expect to go right has gone very right, then significant event audits, which look at one case from beginning to end, and we'll look at that. But trying to find out the best way to do things is research, not audit. And the way I usually illustrate this is that if you want to look at the survival rate of rabbits undergoing general anaesthetic in your practice, that's an outcome audit. If you want to look at how the team members are following guidelines for rabbit anaesthesia in your practice, that's a process audit. If you want to find out the best anaesthetic to use for rabbits anywhere, that's a research project, that's not audit. So you can do in practice research, but it is different. It produces statistically significant generalizable results on a big scale, whereas clinical audit is about what happens in your practice and how you can look at it and how you can improve it. So we talked about outcome audits being mostly about surgical procedures, but they can be around client waiting times, for instance, and that could be quite interesting. In my old practice, the front of house team wanted to do a client waiting time audit, and that brought out a phenomenon called the Hawthorn Effect, where when people are watched, they start to improve, and the vets all got terribly competitive, and nobody wanted to be the one who was keeping the clients waiting the longest. Audit could lead you to benchmarking. And knowledge has benchmarking is when your results are compared against the general results. And this little slide on the right-hand side is from when I visited our local private hospital, which were very proudly saying on their screen in the waiting room that whereas nationally 5% of patients who undergo surgical procedures develop a surgical site infection, and their results in that particular month, the rate was 0.9%. So, I mean, I think clients like transparency. It's great if you've got results of audits. You can shout about them in the waiting room, but also they're really useful for when you're getting informed consent, when clients say, what is the risk of my to my bitch spay? You can say, well, the anaesthetic risk is this, and the risk of having a complication is this. And the National Audit for Small Animal Neutering is all about neutering complications. And that's going to extend into a national audit for all post-operative outcomes and in all species. Canine Cruciate Registry is collecting information about cruciate repair. And SAVSnet have had some great resources around benchmarking antimicrobial resistance, where you can see your practice's results compared to all the other practices. And as I say, in the NHS, there's a lot around transparency now, and being able to look up your surgeon and see what the results are for elective procedures. So I think that's something we should be thinking about. And in the National Small Animal Neutering Audit, all cases of all routine neutering cases are assigned to groups from 0 ran away through 1 absolutely fine to a little bit pink but doesn't need any treatment. 3 needs some medical treatment. 4, oh dear, needs resuturing. And 5, oh dear, death of animal. So, but everybody who's doing it has to know the criteria. Criteria have to be really, really clear. Then they can be put in the correct groups. And the results from the National Audit for Small Neutering are really interesting. I would really hope, if your practice isn't doing it, you'd think about submitting data, because as with all these things, it's only as good as the data that's submitted. But interestingly, more than 15% of cases had some sort of abnormality, and about half of those, about 7.5%, needed either medical or surgical intervention. But 75% completely complication-free. Spays, in cats and dogs, spays more complications than castrates. I don't think we find that particularly surprising. But for rabbits, it is the reverse. So that was interesting. So it's really interesting having these figures, and useful for your practice to submit them, because you can look at your own figures most importantly, but then you can compare and see how you're doing compared to your peers. Process audits, I said, looked at protocols and guidelines. And I think this is where there's so much opportunity for all the team members in practice to get involved. You can audit controlled drug protocols, cleaning protocols, informed consent, as I said, any kind of clinical guidelines. Anaesthetic monitoring charts, really rich area for auditing to see they're filled in correctly, because that's such an important part of the anaesthetic process. So just to finish audit, keep it simple. Choose something that happens often enough. Involve the team. That's really important. Don't do this without the team knowing, because people will think you're looking over their shoulder and start to get paranoid. So it's really important that you're really transparent and the team knows what's happening right from the start. Time spent planning is never wasted. Lots and lots of time to plan. People do need a bit of protected time to do the audit as well. Communicate the results. Completely pointless doing an audit and not communicating the results to the team, and even more pointless if you don't act on the results. Involve the people who do the job in deciding what needs to change, and always re-audit. So they would be my tips. And don't wait for the perfect audit. Start with something and you will learn as you go along. So start with something nice and simple and easy, and you like maybe auditing compliance with off-license medicine consent forms. That's an easy one to start with. Start with something easy, or with the admissions forms, and you'll learn as you go along from that. So as I say, I could talk for an hour just about audit, but we've got a lot more to cover. So yeah, we all need checklists and systems of work, don't we? We were joking before we started today about having a Zoom checklist to remind you of all the things that we should have, that we should check before we start, because we can't keep everything in our heads. It's impossible. So we all need checklists and systems of work. So there are surgical safety checklists, which a lot of practices are using now, following on from the World Health Organization surgical safety checklist, where the team has to stop and think about what might happen, what do we need here, and actually verbalize it, actually go through a read-do checklist. And that's really important, because it makes everybody into a team and means that people are more likely to speak up. But you can use checklists in other parts of the practice too. You can use checklists around case transfer, handover. That's a really, one lot of people are really tired and finishing their shift, another lot of people are starting. So handover between nurse teams, between nursing assistant teams, between vets teams. Checklists can be useful for those, and for anything that's safety critical, a checklist is really important, because missing out one little step, and they came from aviation, where obviously missing out one little step on an airplane can be pretty devastating. And just to convince you that checklists are useful, this is the results of when the World Health Organization trialed their surgical safety checklist back in 2009. So this was just a list people had to read out at 3 stages in the procedure, about introducing the team to each other, thinking about what they were going to do, thinking whether they had the right kit, the right x-rays available, the right fluids. Deaths fell 47%. Complications fell, infections fell 48%. Wouldn't you, if you could go in the exhibition here and buy a piece of kit that could do that, you'd get it, wouldn't you? If there was a new medicine that would do that, your practice would get it. But this is just a piece of paper and some communication. 78% of team members said it had prevented an error. And most tellingly for me, 93% of the team members involved said they would want it to be used if they were the patient undergoing a procedure. So I think that's really, I find those figures really, really powerful about how a system of work, a piece of paper, a way of communicating can be so powerful. So that takes us on to a little bit into systems thinking. You've probably heard a lot about human factors, and human factors or ergonomics is about understanding the interactions of us as people and other elements of a system. And remember, a veterinary practice is a system. And the aims of human factors is to optimize human well-being and optimize system performance. So if the design of equipment doesn't accommodate how we work, we're much more prone to error and stress. We know that, don't we? There's bits of kit in the practice that don't work very well, and you have workarounds, don't you, to how you deal with them. But there's much more likely for errors to occur because somebody might come along who doesn't know what that workaround is. So systems of work should be designed to make it easier for people to do the right things. So these might be checklists and guidelines and protocols, but they might also be physical systems. So if we start thinking about systems, we shouldn't be addressing problems by trying to modify behaviours. We should be modifying the system. We'll never eliminate human error, but we should be trying to design systems that make errors less likely to occur. And we shouldn't be concentrating on the person who made an error. We should be looking at an organisational level, how we could organise things so these errors don't occur as often. And we definitely shouldn't be referring to failures of people as causes of errors or adverse events, but we should be referring to system design flaws, because that makes it all a lot less threatening and a lot more, everybody's going to have buy-in to that. How can we improve the system? Because generally there are not bad people, we just sometimes have bad systems. And I think you probably all understand that in your practices. So this is just a few bits about physical systems, about reducing errors, from car park consulting, where you actually have numbered bays, so that when somebody went out, back in February when it was dark, trying to look for the grey car in the car park when there were 4 grey cars and they don't know which one they're looking for. Systems like in the dispensary, when you provide a medicine, providing the correct dosing syringe that goes with it. If there's 2 different syringes, taking one of them out. When you're storing medicines, if there's something that's high risk, like maybe a hypertonic saline, you store it somewhere separate from the rest of the fluids, or you cover it with red bandage or put it in a bag or whatever. The syringe driver reminds me of one of the case examples on RCVS Knowledge of a practice that had syringe drivers in the kennels and in theatre. There were different makes. The one in theatre broke down, so they got one from the kennels, not realising it was calibrated differently, which led to a fentanyl overdose, which luckily they recognised. So having bits of kit that are all the same in a practice makes for systems to be much, much easier. The automatic dispensary for the, where when you type in the name of a medicine, just that little door opens, is taking the sort of trying to reduce errors in the dispensary to another level. And then the escaping dog, it was to remind me of a practice where they had 2 sets of doors from the kennels straight to the outside world, and it was quite busy and near a busy road. And it was really important that people kept both doors shut, despite endless notices on both doors and endless discussions. That wasn't happening. So in the end, they fitted a klaxon between the 2 doors, so that if somebody opened both doors simultaneously, then the klaxon went off, and that solved the problem. And that was a physical system. Okay, we're nearly at the end now, but we're going to just talk about how the practice deals with significant events. Now, the important thing here is the definition, and significant events came from general practice in human medicine. And a significant event is an event thought by anyone in the team to be significant in the care of patients or the conduct of the practice. So these definitely don't need to be clinical. It's a qualitative rather than quantitative form of audit, but it still needs a structured framework. And it's an opportunity to learn from a single event. So they can be things like the escaping patient and dispensing errors, or they can be more moderate things. Good way to look at client complaints. Great, please record near misses. Near misses are gold dust. Have a near miss book in the practice and record near misses, because you can learn so much from them, and hopefully they never become errors. They can be positive things too, and they're great for communication, teamwork, team morale, because when something's gone wrong, everybody's a bit down, aren't they? So to be able to discuss it and get something positive from it is really powerful. So look what the significant events are. So we could talk just briefly about poor old Mrs. Jones, who took her cat Chew to the vets to be put to sleep and for private cremation. And when she returned to collect the ashes, she was told in the waiting room that there were no ashes because Chew had been sent for communal cremation. So the first stage of a significant event would be to gather the information, the accounts of the individuals, any bits of documents, any consent forms, in this case, clinical records, protocols, client complaint letters, Mrs. Jones complained, and then get everyone together to look at all that information. So everyone, whole team, not just the vets, not just the vets and nurses, the receptionist, the practice manager, the nursing assistants, everybody, because everybody has a different perspective, and putting all those perspectives together is what makes a holistic look at what's happened. So yes, it's a whole team activity, and the meeting must be clear to everybody that the meeting's not about blaming individuals, but it's about improving practice procedures and systems. So in the case of and then it's about looking at what happened. So in the case of Mrs. Jones and Chew, they looked into it. They had a new receptionist on who hadn't had any induction, been thrown at the deep end. She booked Mrs. Jones in on a single appointment. They had a new graduate on consulting who was falling behind and was a bit worried about the euthanasia anyway. Mrs. Jones waited for 20 minutes in the waiting room, was really upset by the time she went in. No nurses to help the vet because one was helping with an emergency op, one was gone to the branch to collect some medicines, and one was very busy with redressing a very wriggly dog's leg. So she finished up with the receptionist helping her. Mrs. Jones had told the receptionist that she wanted private cremation, and she mentioned it to the vet Anna at the beginning, but Anna was so upset and traumatized by the whole thing because she had a bit of a struggle to find the vein that she forgot. Wasn't recorded anywhere. One of the nurses came back from the branch surgery and she helped Anna by taking the body through, but didn't know it was going for private cremation. So there was lots and lots to unpick in that, what happened, why it happened scenario, looking for root causes. And one of the ways to do that is the 5 whys, where you basically just keep asking why. Don't ask why once, keep asking why. Channel your inner toddler to stamp your feet a bit and keep asking why, because the first why, the obvious thing of what happened, somebody forgot, is never the whole picture. And if you want to look at root causes, we have some great resources around that. We have a contributory factors checklist that you can use at your meeting to go through all the factors, team factors, task characteristics, work staffing levels. And if you're one of those people who prefers to think about things in a visual form, then we also have blank fishbone diagrams or Ishikawa diagrams, which analyze it all according to process, people, environment, equipment. That particular one is about a client going home without their insulin, but you can break it all down that way. Whichever way you break it down is up to you, but it's a matter of looking for those root causes and not looking to blame people, but looking at how we can change systems. And then root cause analysis needs action, because once you've learned what the root causes were, you need to think about what needs to change. Is there any need for training? Well, I think there certainly was in that scenario we just mentioned. New guidelines or protocols? Yes, I think they need some around the cremation procedure. Further audits? Yeah, maybe a waiting time audit, maybe audit of the new cremation protocol. And writing it up is great, sharing the learning with other people. It's great to learn from other people's errors. And QI Vets is a whole series. It's a practice, a fictional practice that has all sorts of terrible things happen to them. And they always discuss them as significant event audits. They were published in Vet Times. They're all there on the Knowledge website. And if you want to start doing a significant event audit, you could use one of these rather than use a real scenario if you wanted to start with. And also you could submit them for Knowledge Awards too, if you wanted, where you've written these things up. Same with the audits. So it all fits together. If you get involved in one thing, you will get involved in another. So clinical audit might go to benchmarking. Clinical audit might lead to you to create a guideline or protocol, or you can measure the impact of your existing guidelines and protocols of clinical audit. significant event audit might lead you to create checklists. If you've had an error involving surgery, you might start using surgical safety checklists, for instance. Everything's linked together. So once you get involved, I will warn you, once you get involved in a little bit of QI, it will lead you along the path of getting involved in a lot more of it, but hopefully with good results. So just to finish, I'll just finish with the elephant in the room, practice culture. People say, don't they, we need to change the practice culture, but that's too big. How do you start changing practice culture? I've always found that a bit overwhelming. I know it's a marathon, not a sprint, but it still seems overwhelming to actually change practice culture. Yes, we can be nicer to each other, of course we can. But how can QI help? Well, if you do use quality improvement, you have to listen to the team. You have to listen to them as the results of the audit. You have to look at evidence to draw up guidelines and protocols. You measure your effectiveness by audit, so you know what you're doing well and not doing so well. And then you have to be open to making changes. So it encourages a continuous learning and improvement culture in the practice for everybody at all levels. When it comes to errors, QI will help you to use errors as a reason to improve systems and not as a reason to blame individuals. So all those things together, I think, make a big difference, can make a big difference to practice culture. All those things together can improve practice culture by having a practice where people can speak up and are listened to, and the practice, everybody in the practice, everybody's experiences are as valid as everybody else's, and the practice embraces change and realizes that we can't stand still, that we all have to change and move along. So we've got lots of free resources, as I said, so that's me, thank you.
You can find more information about quality improvement and free resources to help you embed quality improvement techniques in your practice at rcvsknowledge.org/quality-improvement.